Virtual orthopedic training in Africa is clearly an important issue, and there are a number of new perspectives in this arena. In 2020, or if 2020 has taught us anything, it's been a big reminder that we must rapidly adopt technology to ensure high-quality training. Virtual education, virtual meetings, and virtual orthopedics has become the new normal around the world. The big question remains, will we return to our old ways as physical distancing policies loosen? Or will we continue to innovate in the use of virtual communication? Let's take a deep dive today with a highly interactive and small group discussion on this issue. Let me introduce a friend and colleague, Edward Kironde, who's an orthopedic surgeon in Kampala, Uganda, and currently serves as the executive member of the Orthopaedic Society of Uganda. Welcome, Edward.
Thank you, Mr. Mo Bandari. It's a pleasure to be here. Thank you very much.
So please go ahead.
All right. So my name is Dr. Edward Kironde. I am an orthopedic surgeon currently at Mulago Hospital. It's a national referral in the capital city of Uganda, that is Kampala. Uganda is a small country in the East African part of the African continent. And we serve a population of over 40 million people. I'm glad to be part of this discussion today. And with me, I'm joined by a friend and a colleague by the names of Dr. Jean-Paul Wacha. He trained at Makerere University, which is also in Kampala, Uganda. He's a trained orthopedic surgeon, and he was a surgeon. He was a doctor previous to that in Congo, which is a very big country in Africa, in the central part of Africa. And following his training, he's been serving both the populations in Congo and Uganda as an orthopedic surgeon. And I'm glad to introduce him to you. Jean-Paul.
Thank you very much, Dr. Edward Kironde. I'm glad to be with you here. Doctor is also my mentor, as I was a resident in Mulago National Referral Hospital. I'm currently practicing in a private orthopedic center called Ultima Trauma and Orthopedic Center in Kampala. So I'm glad to be here, and I'll go straight away to the points of our discussion. When talking of virtual training, I'm looking at it in two different angles. The first one, I consider it in the angle of education, whereby the learner and the trainer, they are interacting using software and being into different locations. I'm also looking at it in another angle of purely training, surgery being a profession whereby we need to master something using our hands. There is also a situation whereby we are creating a simulated environment, and now there is an interaction between a computer and the learner to acquire some skills. So now, coming to the topic, what is the situation here in Africa? This situation of pandemic of COVID-19 has taught us a lot, and at the end I will share my little bit experience during this period, and whereby we've come to realize, all of us, that virtual training is really a necessity. So here in Africa, there is that need for virtual training for several reasons. When I take it into the angle of training the residents or training healthcare personnel in the angle of virtual reality, we've come to realize that there is a need because the current residents don't have enough exposure when they complete their study. And also, there is also that aspect that the trainers are few, and most of them located in urban centers, whereby accessibility to them is not really easy, and there are a lot of barriers. It can be financial, it can be economical, or other things. So interaction with between trainers and learners have become a necessity, and I'll try to give several examples to illustrate that. The foundation of surgical training for centuries has been see one, do one, and teach one. Now, when we consider it in our situation, this is no longer working. The needs of surgeons is really increasing due to the growing of our population. So we need more surgeons, we need more residents. And at the end of the day, in our current situation, we don't have enough exposure during the training. So you don't have enough cases to see. You don't have enough cases to do. And at the end of the day, there is a gap. So there is that need of improving. And we can improve it using different methods. And virtual orthopedic comes in to try to bridge that gap. We can do it using that aspect of education or using that aspect of simulation. Education, we have specialists trained with enough experience, with knowledge, located in different centers, and using some softwares, they can interact with the learners and exchange experience and try to bridge that gap. On the other hand, which I will come to that, which is really something almost inexistent, doesn't exist here on the ground in Africa. The simulation whereby the resident who didn't have enough time to have exposure during his training can access some tools, some simulation as it is used in aeronautic, the flight simulation, which is a necessity because people are handling the life of passenger. That same thing can also be transferred to orthopedics or to medicine to try to bridge that gap of exposure. And at the end of the day, the surgeons or the resident will be confident to go and do something on its own. There is a study which was published in 2017 by Brian George, and the study was talking of readiness for independent practice. And they come to realize after 5 years of training of residents, 30.7% of them, they are not able to practice surgery independently. So there is a gap, and there is a need of now interaction. There's a need for interaction because after training, those people, they have to come and perform surgeries on their own. And that virtual orthopedic will come and try to bridge that gap. And I want just to share a little bit of experience which I've learned during this period of lockdown, being in Kampala and having my heart back home in Congo. Me and some residents who are doing neurosurgery in National Referral Hospital of Mulago, we initiated an online course on trauma to French people in Congo and all over Africa, people who are speaking French. And from April of this year up to now, we have reached 14 sessions of training on trauma in patients, especially the polytrauma situation, whereby we are trying to update doctors dealing with trauma on simple principles which are not yet practiced, like ATLS, like damage control, like trauma in elderly population, and all of those aspects. And it is this time of lockdown which had created that situation, and we have created an online course which can be found on Neurosurgical TV, which is a website run by Dr. John Bennett from the USA. And every time we are giving the course, it is recorded live on YouTube and on Facebook. So it has really helped a lot the people there on the ground to be updated on how to handle trauma cases. And even we are trying to give some type of certificate. So that one was possible virtually, as here in Uganda and other renowned specialists in other countries like South Africa, like Zimbabwe, like France, like Belgium. So that was really.
My apologies. Are you able to let me know when you want me to switch to the next slide?
Yes. You go ahead. Next slide.
Okay, so
Next. So I'm here sharing my experience.
Perfect.
And you can find the online course in French, which was designed for Congo and other countries. And that one was an initiative which started with the current lockdown of COVID-19. Being in different locations, we've been able to update our professional on how to handle trauma cases using virtual training orthopedic. And the other side, which is the simulation, from my experience, I've not yet seen it on the ground, whereby the trainer has an interaction with a software or a computer to have a reality on a certain procedure before going and perform it on the patient. And I think that one should be a new perspective for for Africa, taking into consideration the situation we are in, the current situation of our training. And there is a simple software, simple application which I came across and I'm using, touch surgery. It's something we try to help surgeons to have an interaction, to have a simulation of the procedure before you go in, which can help. It is a type of virtual training which can help the surgeon, which can help the residents to improve the skill before going and practicing the procedure. So I was trying to be a little bit fast to present that situation, and I will leave the other things for discussion, for interaction, to give more details, to give more experience. So I want to stop here. I don't want to take much of the time. I want to leave the rest to Dr. Edward Chironde to also give his talk and compliment me. Thank you very much.
Thank you very much, John Paul. To begin with, virtual learning in Africa, in particular, sub-Saharan Africa, is a new concept. And I would look at it as a spectrum which involves virtual learning in theoretical issues and knowledge, all the way to a spectrum of virtual learning that is hands-on, practical, involving skills labs, just like my colleague Jean Paul talked about, involving simulation of surgeries and probably also examination of patients. So virtual learning in Africa, and particularly in sub-Saharan Africa, has not been around for a long time. My Ugandan experience has been only 4 years old. We started the virtual learning platform in 2017. And the need for this arose from a limitation in access to textbook knowledge, research work, due to limited access to international libraries. So as a small group of orthopedic surgeons and residents at Mulago Hospital, we managed to come together and start a virtual learning group. And with the help of my mentors as a fellow in Canada from 2016 to 2017, I managed to have moderators such as Professor Brad Petrisa, Professor O'Brien, Dr. Jeff Porter, and Dr. Desmond Kwok offer time to us to have virtual learning sessions with them as moderators and small PowerPoint presentations and case-by-case discussions that we had with the residents at Mulago. And we managed to have at least 3 sessions a week, each week for about 10 months. So those were over 100 sessions a year from 2017. And from this, we managed to pick up a few areas to learn that have come in handy now that we're in a situation that is limiting travel during this COVID-19 pandemic. Some of the key points that we learned from our steps taken to initiate virtual learning, again, at the beginning of this spectrum where we're just improving the theoretical knowledge before going through that spectrum to starting virtual hands-on education, we learned that it's important to consider the following as a plan. The first was the selection of a venue. A venue of convenience involved a quiet room large enough to accommodate all the participants. And these were the keynote presenter, as well as other members who are willing to take part in the discussion. We had about 10 to 20 participants per session. And at the time, there was no social distancing by 2017. So the room we had was adequate. But the other option that we've come to learn in this pandemic period is that the connection can also be done by individuals setting up their own connection points via phone, laptop, and personal computers. So these 2 options are very key in planning, and we found them very handy as we begin virtual learning in Africa. The second is timing. We had the challenge. Our moderators were either on the West Coast of North America or on the East Coast. So that is a time difference ranging from 7 hours to 12 hours away from the East African time. And that meant either one group was going to sleep or the other was waking up. And in order to achieve harmony, we had pre-communications via email or WhatsApp to notify and confirm the times of the discussions. And to make it clear, each discussion was set for an hour, strictly an hour. So another key point in planning was timing, and is still very important. The next is internet connectivity. We've had a big challenge of very efficient and reliable internet connection in a country like Uganda, whereby the internet speeds are varying from slow to fast. So it's very difficult to find a reliable internet service provider. The cost of connectivity to the internet also varies between service providers. Some have been very expensive, while others are moderately affordable. But considering the competition amongst internet service providers, we've been able to get affordable internet connection, and this has helped and enabled us to communicate. However, some of the challenges we faced per connection involved interruptions in connectivity, either due to weather or very slow speeds, eventually leading to a disconnection of the connection. The next area that's key in the planning is considering the virtual learning resources. So these are the audio and visual aids. We had, fortunately, a very good laptop with a good camera providing a good visual system, but would have loved to have something more efficient, maybe a projector and a video camera to capture every member participating in the room. Amongst the audio aids, a good microphone and good speaker system are very key. We found that even in areas where the environment was not quiet enough, these played a key role in helping with the communication and maintaining the flow of a discussion. The next point, we noted that skin learning virtually is selecting a very interesting topic, one that keeps all participants very attentive and very involved in the discussion. Again, the group involved residents and surgeons. So it was key to make sure that everyone had something to learn, and that the topic chosen was one that has been not routinely handled in depth at the institution of learning. So the additional moderation from an expert in the field gave the participants more interest to take part in the discussion. And then lastly, having a skilled moderator, keynote speaker, as well as participants helped a lot in making sure that there was a continuity, a very good flow of a discussion. These are the areas I would say we found to be very important in the beginning of this spectrum of virtual learning. And from the African perspective, I believe virtual learning is here to stay. At the beginning, our meetings looked awkward while everyone was having the routine ward rounds and case-by-case patient discussions in the clinic or in the ward. The virtual learning was a bit strange, even to the senior participants. But at the end of the day, COVID has changed everyone's perspective. Everyone is using Zoom and everyone is getting on board with virtual learning. Thank you very much.